Good morning, home health heroes. It is I, your humble servant, Amy Register, here with my mama, the home health mentor, Teresa Register. And just to get you caught up, we're talking about home health, value based purchasing. This is a second in a series because my mom told me that this topic is kind of huge. Last week we introduced it and we talked a little bit about how this is a model that has saved Medicare lots of money and also has increased the um, the great results of a lot of agencies. And so it looks like we are due for a nationwide rollout. Mom, tell us more about that.
Okay, I will do that. So, as I was trying to prepare this, it's kind of like, the question, how do you eat an elephant? One bite at a time. So this is going to be the second bite, but this is really a huge topic. So just to give you an idea of how much detail there is in this whole issue, uh, the document, the final rule on this is 528 pages long.
Ooh.
So, sorry. So, it was filed. The official document was filed on November 2nd at 4:15 p.m. and it should show up in the Federal Register on the 9th. So in 4 days, you should be able to go online to the federalregister.gov and locate it if you want to actually read those 528 pages. I found it interesting. I looked at it this morning. It has been viewed 3,084 times. So that tells me that people are concerned about what's in this document.
Right. And they should be, it sounds
And
like.
they should be,
Yeah.
yes. But that just gives, everyone an idea of how detailed this is and why we can't cover it in 30 minutes.
Mhm. Okay.
So I've really struggled to try to narrow it down and just to kind of do an overall sweep of the information. It's going to take a lot of detailed um, review and digging through for each agency administrator to really get down to the nitty gritty on how their particular payments will be affected.
Hmm.
There isn't a real standard number or standard set of guidelines because all of this is unique to each agency. And that's because it's going to be every agency is either going to be compared to its own improvement
Hmm.
or it will be compared with other agencies' performance. So you don't know what that's going to look like. it's
Right.
uh, it's just kind of out there, and it's going to be really hard for you to um, try to figure out how your payments are going to be affected. But what I wanted to do today is just kind of hit the highlights of what is going to be changing as of January 1st of 2022.
Okay. Sounds good.
So just to kind of recap what we talked about last time, there were 9 states that were in a test group, and they were paid on the basis of about, 20 some quality indicators, including outcomes, processes, and other voluntarily submitted data. And that model relied on retroactive payment adjustments of 2 years. So an agency could have been paid either 8% more or 8% less than a competitor. Um, because of the savings and because of the improvement in the quality, they've rolled this out to all of the states, but the old the old system basically goes away. So even though people have dealt with value-based purchasing in those 9 states, there's going to be quite a few changes. And so everyone is actually going to be experiencing this new stuff. And it may even be a little more confusing to the ones who have worked with it in the past because of the changes that will be implemented.
Oh man, they know just enough to make it dangerous for them.
Yeah, just enough to be confusing as you know as they go forward.
Wow.
So,
Hey, Michelle, happy Friday to you as well.
hello. So here's what is going to happen going forward. First of all, it will be mandatory for all 50 states and the territories. So it's there's no way out. Every Medicare certified home health agency that receives Medicare dollars will be affected by this.
Yeah, if you're
Secondly,
thinking about moving to Switzerland, now's the time.
I don't know. I don't know how they deal with this. That would be interesting. um, so, secondly, the previous model goes away for all agencies that were providing care to patients in 2019. That year is going to be their baseline year. And then 2022 will be the first, what they're calling the performance year. In other words, the difference in the agency's performance in 2022 will be compared to its baseline performance in 2019. And that is going to be on the basis on which future payments will be determined. So they're skipping over 2020 and 2021 just because of COVID and the assumption that those are not going to be, quote, normal years. So
Mhm.
that's why 2019 is being used as the baseline year. Third, all agencies will be competing based on the measurements of a limited number of quality indicators. And those indicators are going to be obtained from the OASIS data that's submitted, as well as claims data. Fourth, the end result will be a payment adjustment, and that will be a maximum payment range of 5%. So it could be 5% more, 5% less, and it's assumed that most agencies will fall somewhere in the middle. If you think of a bell curve, that's kind of what they're anticipating, that some agencies will do better, some agencies will do worse as far as payments. And with the very narrow margins that we deal with in home health, I'm sure every agency is going to work hard to try and be in at least the middle and,
Mhm.
above middle somewhere.
That's so
So,
weird to me because if they start comparing agencies to each other and everybody's lifting their quality, then it seems like you could get penalized even though year on year you are increasing your. It's a little scary to me.
it is. It is. And you're exactly right. The idea is that everyone's quality is going to improve, but as everyone's quality improves, you can still be doing really good quality of care and be in that lower part of the bell curve, you know,
Yeah.
because everybody's being compared with everybody else. And so, yeah, it is. It's puzzling to me that they're using this approach, but again, it can and probably will be modified again sometime in the future.
I hope
And
so. It seems like a good idea for like a couple of years to get everybody chugging along, but then it seems like you need to do more rewarding based on holding steady than you do on growth at some point.
so there is. I'll go into that a little bit because there is a provision that's going to help take care of that, but um, it is kind of scary. You're
Yeah.
not quite sure what's going to happen. and I'll explain the achievement score versus the improvement score in just a minute.
Oh, okay. That's good.
Yeah.
I'm not Catholic, but I feel like praying the rosary for home health.
um, so, so what is a little bit confusing about this is that you've got 2019 as a baseline year, you've got 2022 as the first performance year, but it won't hit the home health agency until 2024 because they are going to have to calculate everybody's, new payment, and that will go into effect for the fiscal year 2024. So it is a little bit confusing. 2019 is your baseline year, 2022 is your performance year, 2023 will be the time that they're looking at all of this information and calculating whatever needs to happen. So it will actually be in place. Your financial impact will hit in 2024. So hopefully that makes sense. And then, as I mentioned, once they get this data from all of the agencies, they very well may make some adjustments for the future. I would anticipate that based on what they find, we will see some changes again for 2025.
Mm-hmm.
So there's something called TPS, as we all like to say. We all like these abbreviations.
Mm-hmm.
It stands for Total Performance Score, and it will dictate the agency's standing relative to the payment adjustments. And there are two general ways that the total performance score is calculated. First is the possibility of an achievement score. If you're an agency that is really performing well and you're very efficient, you've got a great QA program, your patient outcomes are great, your star ratings are great, it's possible that your score would be best calculated as an achievement score.
Mm-hmm.
Most agencies, I predict, will actually do better on the other type of scoring, which is called the improvement score. Both scores are going to be calculated for each home health agency based on the data that's submitted. And they have very complex algorithms that will be used to calculate that. But your total performance score that is going to be applied will be the one that benefits the home health agency the most.
Okay.
So whichever one gives you the best financial outcome is the one that they are telling us that's the scoring method that will be applied.
I like
They'll
it.
calculate both. And again, the calculations are quite daunting. I will plan to go into some of that the next time we have a session, because it will take another one to get through this.
Unless you
But
guys say, no, we don't want to do math, then we
yeah,
won't do
we
it.
don't want that. We don't want to do that. But I think agencies are going to want to understand a little bit more about. I'm still not going to do the calculations, but I will give everyone the basis on which those calculations will be done.
We can make a slide.
Yeah, that's a good idea.
Okay.
So again, you will either be paid on the basis of an achievement score or by an improvement score. So most agencies, again, are going to probably be beefing up their QA program and really honing in on some of the OASIS answers that will form the basis of some of their improvement scores. So when that happens, you will see an actual improvement in the score. Um, as I was thinking about this morning, I was thinking, supposedly these 9 states that were in test states showed an improvement in quality. I've been in this industry a very long time,
Mhm.
and I'm guessing that that might have been more of because people learned better how to fill out the Oasis tool
Mhm.
rather than necessarily an improvement in quality. Um,
You're a little
I,
skeptical about the
I'm a little
quality.
skeptical,
Hmm.
but it did apparently save some Medicare dollars. So that's, I guess, a good thing. But as people learn how to accurately answer the questions when they're doing an assessment of a patient, when they're really good at being accurate in how they provide those answers, and that data feeds into a system, you're going to see improvement just because the questions are being answered more accurately. So, I mean, that's my personal opinion. Um, Hopefully, there is improvement in quality as people really work at this a little bit more. But like I said, I've been in the industry a long time, and I think part of it is we've had a lot of we've had a lot of new home health agencies, which means there's a lot of nurses coming into the home health industry that are not familiar with how to fill out an assessment. And so, unless an organization does a really good orientation and training program of new nurses, it's very possible that they're just, doing their best to answer the questions.
Mhm.
But some of them are, it's kind of like splitting hairs on some of the assessment questions. So we'll see. I'm sure it's going to show improvement just because we're going to pay more attention. But
Mhm.
honestly, a lot of agencies are doing really good care already. So anyway, that was a little digression, but I
Yeah,
think
that's
I think there is some truth to
mhm. That's interesting.
it. So in the previous value based model that were used in the test states, each state had two cohorts, they were called, or two categories. Now there will be two national cohorts, one
Mhm.
for small agencies and one for large agencies. And how that will be determined is that agencies that aren't large enough to participate in the CAPS program will fall into the small cohort category. Um, that will be, we think that's maybe around 800 agencies that will fall into that small category. Normally, um, the CAPS section of the calculation represents about 30% of the score that is going to be used for figuring out the payment. And so, if an agency is too small to participate in the CAPS program, there will have to be an adjustment to that calculation,
Mhm.
um, because obviously we won't have that 30%. So the other two areas that will be used are probably going to be more like 50% each
Mm.
instead of right now it's 35, 35, and 30 that makes up that scoring method. So without the section on the caps information, they're going to have to do some other kinds of calculation. Right now, it looks like an agency would be eligible to be in the small cohort if they have 40 patients or fewer within the defined time period. And that
Mhm.
defined time period is likely to be the 1st of April through the end of March the next year. But we'll know more for sure when all the details come out. So, what I know people are wondering, what are the quality measures and where do they come from? At least that was my questions. So the quality measures that are built into this payment model are based on the National Quality Strategy domains. And people probably are not real familiar with that, so I thought I should probably go over that briefly.
Yeah, I don't know what you just said.
Yes, the National Quality Strategy was published in March of 2011, and it is led by the Agency for Healthcare Research and Quality on behalf of the U.S. Department of Health and Human Services. And how that came about, more than 300 groups, organizations, and individuals from all sectors of the healthcare industry and from the general public were asked, and they provided comments for the development of these quality domains or areas that were determined to be categories of quality for healthcare services. And
Mhm.
based on the input that they received, they came up with 6 priority areas, and those were determined to be the ones that would address the most common health concerns that we face as care providers. So, what CMS is trying to do as they're developing, or as they developed this value based purchasing, is they've tried to tie these quality indicators in home health to these national quality domains.
Mhm.
So the data to determine the alignment with these quality indicators are going to come from the OASIS data, from claims data that's related to inpatient providers, such as skilled nursing facilities and hospitals, and from the agency's CAPS data. And to kind of explain on this second one, on the claims data, if a patient is in home health and they go into the hospital, there's a data bank called the Chronic Conditions Warehouse. And and in that data bank, CMS will know that that patient was in home health but went into the hospital for some reason. They
Mhm.
can tell by the coding in the hospital and the difference, in coding and the transfer OASIS information. They'll be able to tell that this patient either went to the ER and was sent home, or went to the ER and was admitted, or was admitted by their doctor. So, this chronic conditions warehouse of information will will be part of the calculations. And at least what we anticipate right now is that there will be some kind of adjustment in payment based on how well home health agencies keep patients from having to go back to the ER, or for being admitted to a hospital for some kind of an emergency kind of situation.
If
So,
it's related to what they were in home health care for,
sure,
then they
yeah,
look bad, and the warehouse knows it.
right. Well, they'll at least investigate it based on the coding and the details, the diagnosis and all that stuff. So, yeah, they'll actually have all these algorithms working together to figure out if a home health agency has a higher than normal or expected rehospitalization rate, or
Mhm.
if they have a lot of patients going to the emergency room and either being discharged with, a problem or being admitted.
Yeah.
So, I guess all of this to say that there's a lot going on behind the scenes when people submit their OASIS data, when they do a transfer OASIS to a hospital for an inpatient stay. There's just a lot of stuff that is kind of invisible to us, um,
Mhm.
but it's going to be used and it will impact agencies' payments.
You know what? I first of all, 2 points. Number 1, this warehouse is like the first name that I've ever liked in home health related care. I like the warehouse idea. I can wrap my head around that. Okay. Second of all, I don't think that most home health agencies are into passing the buck, but I know that there are some people who this is a tiring profession. And like I put in the comments, I'm so thankful. Every time we have a podcast, I'm so thankful for you guys doing what you're doing. I know that with any kind of caregiving, you can get fatigued. And this just lets me know you're not able to pass the buck. If you do pass the buck, it's going to show up in your earnings the next year, and it might be delayed. Like you might get away with um poor care and just being like, oh yeah, well they went to the ER. But now it seems like it's kind of big brothery, and it's going to be tracing everything, and you just cannot plant a crop that you don't want to harvest next season.
Yeah, it used to be in some agencies. I will tell you, one of the agencies where I was a director, our medical director said, we don't need to provide, after hours care to patients. If they call and there's a problem, send them to the ER. And that is the way some agencies have practiced in the past, but that's not really the trend. The trend and the expectation is that you foresee any kind of issues.
Mhm.
You're hopefully paying close attention to what's going on with your patients, and so you're not as likely to be surprised and have an emergency situation after hours or on weekends, because you're thinking ahead and you're paying attention to their vital signs and you're doing the kind of education with their medications that you're supposed to do. So yeah, it
Mhm.
does put you on notice.
Mhm.
And agencies that have been in the habit of just having their after hours nurses send patients to the ER, they're going to want to reconsider maybe some of their after hours protocols.
Yeah, yeah. I mean,
Yeah,
that's a nice thing to do, not wake up in the middle of the night to help somebody. But yeah, if this is rolling into once this person is under our care, they're under our care, and we're gonna get rewarded or penalized for how well we do for this whole human.
right.
Yeah, it seems like such a game changer. And that's what you want, especially when your aid and this company. It does feel like better overall for the patient. That's what I would want if I were under somebody's care.
And
So it
and what
feels
you just
good.
said, Amy, is how I try to uh, speak about this to people. It's, what would you want if you were the patient or you were the caregiver? If you have someone under home health care, and at 10 o'clock at night something happens to their catheter is leaking, or there's some bleeding or something like that, there's blood in the bag, you know they're concerned about that. They don't want to rush someone to the hospital, but they do need to know, is this something that you can take care of at home? Can a nurse come out
Mhm.
and assess the situation? Well, yeah, we should
Yeah.
we should get
Yeah.
out there, and I I like to say, we need to put our money where our mouth is. And if we are truly concerned about patient care quality, then we need to take care of people and think about what's best for them and staff accordingly. And
Yeah.
take care of these people. So yeah, those are the times that you really make a good impression, hopefully, on your patients, and those are the patients that give you rave reviews. So go out there at 2 in the morning, or 3 in the morning, or whenever you need to.
Mhm.
And I should say, call the police for an escort if you need it
Mhm.
at that
Oh.
time. But yeah, there are some dangerous areas that you might hesitate to go to at 2 or 3 in the morning. But if you need to, rearrange your life to take care of a patient, then you need to rearrange your life a little, you know. Anyway, so back to the national quality domains that we were talking about. I just wanted to go over the list of those,
Mm.
because they are forming the basis of these value based calculations. So the first one is, and I've abbreviated these. If you go and read them, they're much longer than my version, but
Oh.
I've just boiled them down to the basics. So the first one is safety. The second is that the care being provided needs to be person and caregiver centered. The
Mhm.
patient's in the middle of this. Care
Mm.
coordination and communication, clinical quality of care. So making sure that we're giving, the appropriate care at the appropriate time.
Mhm.
Um, Population and community health, and efficiency and cost reduction. So in home health, some of these are obviously a little more applicable, like care coordination and clinical quality, and patient-centered care. Those are all really high on the list for home health agencies, but
Mhm.
but all of these are addressed in the national quality domain strategy.
Mhm.
So I am looking at the time, and I knew that we would not be able to get through exactly how these payments are going to be calculated. So I'm going to plan that next time I'll go over the sources of information that CMS will use to compute each agency's individual payments. And I hope everybody gained something from today, and I would invite any questions. And if you have specific questions that you'd like me to cover the next time on value based purchasing, please let me know. And until then, we'll say goodbye for now.
All right. Thanks everybody for joining us. I see you out there. Again, very thankful for the home health heroes. You guys doing what you're doing. You really impressed me. You know, it's not like anyone ever hopes to have home health care, but when you do, you hope to have people like my mom and you, people in your posse. So thanks for doing what you're doing. And in the meantime, if you've got any questions on home health value-based purchasing, like my mom said, please send her a message on Facebook, The Home Health Mentor. And we'll see you next week for part 3. Bring your popcorn and your checkbook. Just kidding. All right. See you next week. Bye for now.
Bye.